And thanks for staying with us here on PM Express. Tonight we are looking at the pandemic still, but we are going to assess the progress so far and review the strategy with those who understand it. Because also of what we are beginning to see with our case numbers. We are now at 2,719 cases, and this is just as of tonight. The president lifted the lockdown several weeks back because of the facts, the science and the data behind it. We've done several weeks in our post the lockdown. The figures, cases are up and climbing. Is something happening in there that requires a change in strategy? So we're going to look at that tonight on PM Express. Also, we are learning tonight recoveries are still going up, which is a good thing, by the way. It is the only positive in the midst of the gloom, and so there is some positive story there to tell. 3,294 cases. The deaths is still 18. If you look at the original balance of things, it's the breakdown is as we know it. Nothing is changing in terms of the hotspots. Greater Accra is leading. Ashanti it's second, and then Eastern, and then Central. But you also will see that Volta is still pretty high. And if you look at the other regions also, we have the Upper East region also recording some significant numbers in terms of the cases. And you can see the map there tells you where we have the COVID-19 cases in red. I want to quickly move on to some of the key things that we've seen over the last few years. The president, of course, lifted restrictions on movement in Kumasi a few weeks back. We've seen the decision was received with mixed reaction. Many said it wasn't the right thing to do, etc. We've moved on from that conversation. 2 weeks after the lifting of the restrictions on movement, the case count, as you see, has more than doubled. We are very close now to 3,000 cases. As far as the COVID-19 is concerned, the figures show level community infections is pretty high also. I mean, the scientists are worried about these community spread because that's where the real concern is. Health experts say that the lifting of the restrictions on movement will erode the gains that we've made. Is that really true? Is that what we are seeing in the last few weeks? On the back of that, I mean, the Ghana Health Service says, well, they still remain in control. The fundamental question to ask as we've crossed this particular important mark of the post-lockdown period is to stop and reassess. What are the experts seeing? What is it that our analysis and the experts' analysis tell us we should do? Should we keep going the way we're going, or we should change strategy? There are a few people who think we should change strategy. If we have to change strategy, what should the new strategy be? We're going to be looking at that today in this conversation tonight on this all-important subject. Stay with us. And thank you very much for joining us here on PM Express. My guest tonight, as we begin to look at assessing the progress so far and asking the question whether there's time for review, is Dr. Titus Bayo. Is the Deputy General Secretary of the Ghana Medical Association. Also joining us, you know him, is Dr. Michael Osu with the KNUSC. He's also a researcher with the KCCR. He's a virologist. Also joining us tonight is Peter Apiahene. They have a fascinating research that we're going to be talking about tonight as part of this. He's a lecturer, Department of Computer Science, Informatics at the University of Energy and Natural Resources. The thing about that research that fascinates me is that the study investigated the effects of temperature, humidity, precipitation, wind speed, and of course, the specific government policy intervention of the partial lockdown on new cases of the COVID-19 infections in Ghana. That is a fascinating piece of research, especially when you look at how the temperature, the weather may affect the spread of COVID-19. I'm fascinated to hear what they found there, but also their thinking around the impact and the effects of the partial lockdown that they've studied. Grateful that you could join me, sir, on PM Express tonight. But I want to start with Dr. Michael Osu. Doc, so we are now seeing the post-lockdown behavior of the virus. What are you reading into the current infection numbers? We are almost at 3,000 now. What's your expert eye telling you when you look at what we see now post the lockdown phase?
Yeah, so a very good evening to your viewers. So having followed the data, lockdown and then after lockdown, I think one of the things that we all observe is a quite systematic increase in the number of cases we are finding, both in the group of contact tracing and also in the group of routine surveillance. Mm-hmm. So just once again to recall, so the routine surveillance are mostly those who may come to the hospital with signs or clinical signs and symptoms of disease, and for which they will test positive. Either they will call you to come to them at their homes, then samples will be collected, or they may be rushed to the hospital and then seek medical attention. And then the contact tracing and linked to positive cases are those that are followed up at the communities. Either their contacts are followed up, or maybe some kilometers mapped out from where they are, and then you are able to understand what is happening. So what is important is that both are increasing, both routine surveillance and the contact tracing is increasing. But I was just trying to look at the data from the 22nd of April. If you look at the routine surveillance, we started from 2.46% out of over 17,000 tests. Then we moved on to about 2.7, that was somewhere around 28th of April. And then we are now around doing about 3% out of about 30,000 tests. So if you look at the trend, then you will begin to see that the number of hospital cases is increasing systematically by point. And this is going up, telling you that people who are reporting to hospital is gradually going up, and we need to pay very much particular attention. Similarly, also at the community level, we started from somewhere 1.06% out of about 77,000 tests somewhere in 22nd of April. And this increased to about 1.24% out of 82,000 tests somewhere in 27th of April. And then they move on to 1.5% 1st of May, and 2nd of May, we are doing about 1.7% out of about 98,000 tests. So this fits very well with the behavior of this virus, where the virus begins by establishing itself in the community, where you have a lot of asymptomatic carriers, asymptomatics around. Once they begin to build the base, then you begin to systematically have increase in the number of hospital cases. And then as the hospital cases begin to mount, then you may have about maybe 4 to 5% of them who become critically ill. And if the hospital has space and they have the flexibility, these people can be managed and they can easily recover. Mm-hmm. But then when pressure begins to mount and they are unable to do that, then you begin to see some deaths occurring. So, well, it's expected that once this virus enters into your country, you cannot reverse it. It's going to increase. But what you try to do is to manage the spread so it doesn't hit you to the point where you feel so much pressure, but you can space the spread of the virus to enable you have the opportunity to manage the few cases that will come, so you can deal with it. I mean, what kills many people in the other countries is that if you have a hospital bed of about 100 beds and maybe 10 ICUs, and you have 500 cases coming to you, obviously you will know that the 100 will get their beds, the few 50 will get their ICU, but the rest of over 300 will not find beds, and this is why people die a lot. So if you can space the 100 for the next 6 months, and then you can deal with the few 5% that develop the disease, so you can have a space for them and manage them. As I said, you should not be surprised when the counts increase. For the counts, it's going to increase. Every day counts will come. But what is significant is that if you're able to space and spread it and manage the few who have the disease, you are likely to succeed, because they will recover, they may get well, and then you won't have the full impact of the virus. But then if you don't play it out well, and you have cumulated numbers of those who are sick coming and mounting pressure, then you begin to see what others see, which is what I think that we should expect. But for me, for now, yes, the cases are high. The numbers are increasing for both hospitals cases and both community cases. But I think as of now, from what I have seen and observed, we have not reached the point where pressure is mounting at the health facilities. We are not seeing that yet. I think the few that are coming are being managed, and that's how they are managing. People are recovering, which is for me a good news for me there.
Let me bring in Dr. Titus Bayo. Doc, what are your members seeing at the various health facilities across the country?
Good evening, Evans, and then good evening to the co-panelists. Indeed, I think I agree to a large extent with what Dr. Osu has said. The numbers coming in, you realize that most of the people are being sent to the mild, moderate cases are being sent to the isolation centers, and those are recovering quite well. But we are having some good number also coming in through the main hospitals and then filtered through to the treatment centers or isolation centers. But what is significant is that, and I think that is why I think we should be paying a little bit more attention, is what I will call non-COVID or COVID-related deaths. Because our mortality figures, as we are seeing, need to be disaggregated and well-defined. It is pretty obvious that there are some deaths that are not considered either COVID or are COVID-related but may not be counted as COVID. And I think we have to look at that.
Explain that for me when you mean they may be COVID-related but may not be added. Well, give me examples of this, just so that we can understand and follow you.
So what is happening is there are complexity of factors. Currently, the system is reporting people who have come in, have been diagnosed with COVID, and are either at an isolation center or treatment center and have passed. Now, we have situations where people have come in, samples have been taken, they've reported with something else, and then by the time results come in, they are dead. These results may come and show that they are COVID positive. I have cited a release to the press this evening, for instance, of Lebu saying they've had 100% treatment for most of their patients.
Yes.
We are also aware of the same hospital announcing to us of a child who came in with something that they initially thought was rabies or something else, and eventually the child died and turned out positive. So how do we interrogate these figures? Now, the other side of it is when I call the non-COVID deaths. These are the other patients who may suffer what I call collateral damage because of COVID. You have people who will come in, may have symptoms suspicious of COVID. They may not be COVID, but because people may not be adequately prepared, either PPEs may not be there, people will be waiting for samples to be taken, or they are looking for adequate PPE before they can attend to the patient. Unfortunately, we may lose people who are not COVID. Even when samples are taken, this may come back as negative, but they have died because they were suspected to be COVID, or they exhibited symptoms similar to COVID, and either the healthcare practitioners did not feel protected adequately to handle, or they had isolated, were waiting for samples, and some necessary interventions were not taken. And then the person may end up dying, and that is what we call the non-COVID death. Some of these non-COVID deaths may even occur in homes, where people, for fear of contracting COVID at the hospitals, may not show up to the hospital. Secondly, because of stigma, a lot of our patients do not, even when they now start to show symptoms of COVID, fear that if you come in and you are diagnosed, you'll be sent to an isolation center. And therefore, your entire family will be stigmatized against. Now, some of these people may remain in their homes and may end up dying or be brought in dead. During the period of this time, we've had patients in other hospitals, we've heard of reports, who are coming, brought in dead, some of which were never diagnosed as COVID. We don't know what the underlying pathology might be. So can we attribute to a normal delay in health-seeking behavior or an apparent fear of contracting COVID at the hospital, or fear of being diagnosed with COVID, and therefore people delay in coming? So I think whilst we keep our eye on just the figures that are popping up and analyzing them, this is the other aspect we need to be looking at, the non-COVID deaths in hospital, out of hospital, and then the associated factors. And then when the deaths are reported, we really need to go into it. What defines a COVID death?
Yeah, I mean,
is it somebody who has...
That point you make there is a point I want to just interrogate a bit more, because I've heard, again, it's good that you're talking about this. Some of your colleagues have actually said to me that there are cases of people dying. It is post when they are dead that they get the results come in and realize that they are COVID-19 positive. The question then becomes, are we adding those? How many of these cases are there? And are we adding those to our numbers that we have? I mean, let me ask first, Dr. Michael Osu, very quickly. I want to come back to Ms. Appiah-Henning very shortly, but I want your take on this, Dr. Michael Osu, on this. Those cases, should we be adding those to our official figures that we put out?
Yeah, so I think it's a quite interesting point that Dr. Titus Bayu raised over there, and it's something that we perhaps need to look at, because I think there's a protocol on reporting deaths, which, to the best of my knowledge, these are deaths due to confirmed COVID positive patients. And ideally, we also have a base number of deaths that occur in our health facilities, which have been occurring even if COVID had not come. So it's a complex area. If you want to measure the impact of COVID on the collateral damage to other silent killers, it could be people who ordinarily could be asthmatic, and because of the COVID situation, they may not get the immediate care, for which case they may lose their lives. I think it's good to understand this, but you need to weigh this against the baseline number of deaths that usually occur. So you don't overly extrapolate this and say that because of the COVID situation, you've had quite a number of them. For instance, in the US knows that almost annually they have quite a number, over 300,000 people who will die of influenza. So they are beginning to project that if COVID comes in within the season of influenza, they may have 2 times the number of deaths, in which case they can measure deaths which would ordinarily be due to routine influenza infections, and then deaths which will also come due to COVID. But I think it's an interesting point. Perhaps you want to see confirmed COVID deaths and probable COVID deaths, but this is quite complex because of a lot has to go into this, and data will have to be collected at all the facilities. Adequate investigations must be made to understand how this occurred before this will come out. I'm not sure if we'll be able to go there, but it will be interesting if we begin to look at that area for me.
I mean, very interesting point. I'll come back to you, Titus Bayu, but I want to quickly bring in, of course, our friend, Ms. Appiah-Henning. So, Ms. Appiah-Henning, tell me this. Part of your study that you did, from what I've read, it also investigated the effects of the government policy intervention of the partial lockdown on the new cases of COVID-19. What did you find? Did it achieve the results that it set out?
Okay, good evening, Evans and your viewers. Actually, it's true. We were trying to find out the policy intervention that the president, implemented. But one thing that we must know as Ghanaians is that our lockdown was partial. And comparatively, if you compare our lockdown to elsewhere, some were total lockdown. So we were trying to look at the impact, whether the president or government were able to achieve the result. And from our studies, per the data that was available to us, and the data source was what Ghana Health put out, which was also captured by WHO. It shows that the impact was significant. It means that when government imposed the partial lockdown on the 2 greater cities and begin to do enhanced contact tracing and testing, they were able to achieve the results. So ideally, if you look at our hypothesis, we were trying to test the hypothesis that the partial lockdown was not significant. But looking at the studies, we had a p-value of 0.01, which means that it was very, very important that the partial lockdown was significant.
Now, when you say partial lockdown was significant, in what specific aspects?
In the aspect of trying to contact, trace those who the health expecting that they have had contact with the positive patient or those who have been tested positive. You remember the president didn't impose partial lockdown or total lockdown in the whole country because the advice, or maybe the health expert advised that the two greater cities and its environs were the epicenter, that is Greater Kumasi and its contiguous district, Greater Accra, Kaswa, and Tema. So when they did that, you realize that within that time frame, they were able to gather enough data. That is why when the president was even lifting the partial lockdown, he made a significant, he mentioned a significant number of sample, meaning backlog. So within that period, the health expert, that is those who were doing the contact tracing, were able to capture or meet those sample space. You know, before they even came out or started the partial lockdown, they had an idea of a sample space, that is people that they want to capture. So when the president the president and his team decided to lift the partial lockdown, the idea was that, or the information or the advice that they gave to the president was that now maybe we are okay. We've been able to capture those sample space, that's those within the sample space, we've been able to capture them, we have tested them. That is why within that period, we've had a significant number, or we've had the number increasing. But unfortunately now we are yet to hear from the Ghana Health Service and also the Ministry of Health to tell us that the data, the new data that is coming out are still with the backlog, or are they new cases? That is what we are yet to confirm. But significantly per our studies, we can confirm that the partial lockdown that was imposed by the government impacted positively. It means that the partial lockdown, the aim or the objective of the partial lockdown
was achieved. Let me bring in Titus Bayo. Titus, so, and this question will go around. If you look at where we are today, post the lockdown, are we making progress in the right direction? Are we achieving our aim? Are we flattening the curve?
We have.
Yes, Titus.
Okay, so I think we are making progress. Yes, I think we are making progress, but I cannot say if we are flattening the curve or not because of the nature in which we get data.
So what sort of progress are we making?
Yeah, we are making progress in terms of testing. We have increased our testing capacity a lot. Now we have decentralized the testing a lot, and we can see a lot of progress in that direction. We are also seeing progress in the number of people who are trying to adhere to the social distancing protocols, though not perfect. At least there is some semblance of people trying to use the face masks that is being prescribed. However, there are a lot of areas that also needs much to be desired. And I'm sure maybe in another round of questions, I can come up there. But we have made progress in the number of testing sites and the number of tests we are doing. But associated with that is still a significant delay in the reporting. I am sure now that we are having a lot of testing sites, that delay will soon be a thing of the past.
Okay.
And I doubt if the delays we are having in terms of the reporting is an issue of the testing site or their clerical or administrative issues. Because we are having evidence where various regional authorities are issuing reports, and 4 days, 3 days after that, before we see it uploaded on the website.
Yeah.
And then you ask the question, because the regional authority, like the Regional Coordinating Council, for instance, of the Volta region, will not issue a report that is not confirmed. And so if they issue their total deaths as of the 1st of May in a press release, and that gets updated to the Ghana Health Service website on the 4th of May, then you want to find out, are these delays really from the lab? I doubt it. So I think in that area, the nature in which the data is being fed to us it's very difficult for anyone to talk about flattening curve. Like the earlier speaker said, we cannot even tell if these new figures are from still the backlog or their new data. And when they were actually certified from the lab, could it be that they were all certified before the 1st of May and we are now getting it? How can one make a projection of flattening of the curve?
Yeah.
So in that area, I think we don't have enough data to make any comment on whether we are flattening the curve.
I mean, Dr. Michael Osu, that's the data that we can all verify, indicate to you of us making positive progress in winning the war against COVID-19. What's your reading of the situation? Hello, Dr. Michael Osu. Okay, I doubt if you can hear me. Let me see if we could bring in Mr. Piani. Mr. Piani, can you hear me?
Yes, I can hear you.
I mean, so you made a point already. I mean, based on your research that you did, that you found progress. But you did research also on the impact of the weather, on the spread of COVID-19, temperature. Well, what's the finding? What did you establish?
Okay, actually, when we saw that initially when the pandemic started, and those of us in Ghana, we realized that even there was an instance that we reported a case around 12 March. And at the same time, we also saw that countries in Europe and America has also started reporting cases. But when we saw and when we realized that their numbers were increasing exponentially, whilst Ghana, we were still, with respect to the data and also the graph, we were still at the lower rate. We begin to ask questions. And those of us in academia, we decided to do some research and find out. So we did an extensive literature review to find out. And a lot of researchers, both in America, Europe, and China specifically, a lot of them, about 70% or 80% of research have shown that temperature were impacting on the transmission of COVID-19. But unfortunately, there was no African case, meaning there was no research to show that Africa, the temperature that we have, was also affecting the spread or the transmission of COVID-19. So we quickly did the research, and with our research, we found out that climatic factors like relative humidity, wind speed, temperature, and precipitation. But unfortunately, wind speed was not affecting it that much, meaning it was not all that significant. But temperature and relative humidity was affecting the rate of transmission, meaning that when temperature increases, the rate of transmission also decreases. But when precipitation increases, the rate of transmission also increases. So an increase in temperature and relative humidity reduces or decreases the rate of transmission. And that of the precipitation is the opposite. So meaning that once we are entering rainfall, and we all know that precipitation is about rainfall, the rainfall will affect our rate of transmission. So for me and my team, we are not surprised that whilst with the advent of the rainfall, some of our figures has begun to go up, because precipitation goes up per our model that we have developed. Precipitation goes up and transmission also goes up. But whenever temperature and relative humidity increases, our rate of transmission also decreases, meaning that going forward, once we are entering the rainy season, policymakers should up their game, because per our research, it means that once we are entering the rainy season, it can affect our rate of transmission.
Dr. Titus Bayo, quick comment. What's your reaction to that research?
Well, it's not an area of strength, but this is from academia, and I would say that if per this research we are projecting increase, it means that we will have to increase our testing. And I think we will be able to back this research finding if we are getting real-time test results, so that we can tell on a day-by-day basis whether during the periods where we are having rains, for instance, we are getting an increase. I think the major difficulty, and I don't know, maybe they have access to data that the rest of us have not had, is whether they are getting the actual numbers from daily testing or from the backlog, which is very difficult to disaggregate. But per the model and projection that they have made, it means then that if we are going to a rainy season, we should expect an increase in the infection. We would hope that that increase in infection will still be milder forms of the infection and will not lead to deaths. And therefore, if we increase our testing and real-time reporting so that we can tell on a daily basis how many new cases we are getting, then we may be able to validate this model that they have come up with in the raining season that we have entered, and then immediately put in measures. Because our best bet as a country is to make sure that we make our diagnosis early before people come in with symptoms. Yeah. And I am happy when most of our reported cases are from enhanced surveillance and contact tracing, instead of from routine surveillance where people come with symptoms. Because the more people come with symptoms and they are diagnosed, the more likely that they will get into a severe form of the disease and will require treatment. But if they are picked from routine surveillance or contact tracing, means most of these people are asymptomatic. We have just they have had a contact with a positive case, and we have gone after them. In that case, we are going ahead of the virus. And then we don't get them in a severe form that will overwhelm our system. Like Dr. Osu mentioned earlier, what we are trying to avoid at any point in time is that the proportion of patients with this condition that are visiting the hospital should be that which our hospital have the capacity to handle. So we don't want a lot of people arriving in severe cases. So if this prediction model is anything to go by, we need to quickly improve on our testing and our reporting and our detection rate so that we'll get a lot of people very early in this rainy season that we are going into. Yeah. And I'm sure the daily reporting may validate or prove otherwise to this prediction. Yeah, that I mean,
and I guess if what the research is saying anything to go by, then also we probably have to pray that this year the rainy season delays a bit more, so we could have more sunshine that will reduce the rate of infections, at least until we get a handle on it. Then we can have the rain pour.
Evans, but that prayer, we would have to pray cautiously.
Because of the impact on agriculture.
There is economics to it as well.
Absolutely, I agree with you.
Already, our economy is hit hard. We are in a major planting season for our farmers. So a delay in the rain means that we will survive COVID and we'll go into starvation.
Yeah, hunger will kill us if COVID doesn't.
I think, exactly. Yeah. So I think we should rather prepare optimally to handle any increased numbers. Yeah. And that means improving our detection rates and quickly diagnosing and managing them.
I mean, I want to take a quick break. When we return, I'll be examining this a bit more. I mean, that research is, I guess, supported by what the US government also did, which in essence found that heat, significant heat, also kills, in fact, sunshine contributes quite significantly in obliterating the virus. And so I guess it backs that point there. Well, when I return, I'll bring in Dr. Michael Osu, who we lost earlier, on what the numbers are telling us and whether we should be making a change to the strategy with what we're currently seeing. Stay with us. You're still live on PM Express tonight. My guests joining me to assess the progress we've made so far in our COVID-19 fight post the lockdown several weeks on, and also looking at whether there's a need to change strategy. Dr. Michael Osu with the KCCR, the testing center in Kumasi, and also with the KNUS. He's a virologist there, Deputy General Secretary of the Ghana Medical Association, Dr. Titus Bayo, also joins us, and of course Peter Apiahene, who is a lecturer, Department of Computer Science, Informatics, University of Energy and Natural Resources. Dr. Osu, whilst we lost you, we had the results of a fascinating research done by Peter Piaheni and co. And that, in essence, in summary, showed that temperature, I mean, when the weather is hot and the sun is burning and is humid, it reduces the spread of COVID-19. However, precipitation, rain, encourages the spread. It sort of fuels the rate of infection goes up. What do you make of that as a virologist?
Yeah, this is not surprising, except that we did not have evidence in terms of mathematical models to prove what we are seeing. When the disease started from China and entered into Europe, many of us were asking that, why does it follow an exponential curve? And why do you have multiple folds of people getting sick and dying? And then as soon as it entered the African continent, we're beginning to see that the exponential nature of the disease and the deaths does not seem to follow that pattern. Yeah. And we understand experimentally in the lab that the virus can survive for more than 14 days at a temperature of about 2 to 8 degrees Celsius. If you place the virus up to 22 degrees Celsius, that's at room temperature, it can survive for exactly 14 days. If you place it at 56 degrees Celsius, it can survive for about 30 minutes. And then at 75 degrees Celsius, it can survive for about 5 minutes. So experimentally in the lab, this has been proven. So it is not surprising that at high temperatures, it doesn't mean it wouldn't infect, but then the reproductive number of the virus, which is about 2 to 3, will be reduced to about 1 to 1.5. So you should expect that in high hot areas like sub-Saharan Africa, the rate of transmission will be slowed. And this is why I think we seem to have high infections in a lot of the cold areas and seem to have low transmissibility in this part of our world.
And there's a follow-up to that. There's a follow-up to that. There's a policy question which Peter Piaheni raised, which is that now that we are entering into the rainy season, where there's attendant cooler weather, he says that the research that shows that there's going to be, the correlation will mean that the infection may be higher than when we were in a drier, more humid, sunnier temperatures. So that should definitely influence policy. His policy proposal is, of course, Dr. Bayo says we should test more. What's your recommendation now that the weather is going to be changing?
It's possible. It's possible that as the weather changes and then you have the rains coming in, the temperature goes down. You know, the normal flu, before COVID, if you have rains coming in, you have flu. Yeah. And this flu could be caused by a number of respiratory viruses, such as rhinovirus and the human coronavirus. The first 4 types of human coronaviruses, they are most predominant during the rainy season and mostly also around the Harmattan season. And you have the respiratory syncytial virus, which could also be predominant. You could have even things like malaria also coming in, and you could have complications of cholera coming in. So rainy season comes with its own problems. So you will expect that if you have COVID on top of this, the situation may of course increase compared to when you don't have. So as I said, this is observed across board, but it's good that you have evidence of data to prove that this is what is happening. But then let me touch a bit on the testing. Before I went back, I know Dr. Titus Baby was talking about the delay in testing. I was not too sure what was happening. No, there are 3 phases of testing. I mean, the phases that the sample goes through. We have the pre-analytical phase. The pre-analytical phase has to do with what you do before the sample comes in. How do you collect the sample? How do you package the sample? How do you label the forms? And you have to deal with that. Is a huge area. So if the one bringing the sample does not label it properly, the label may go off, and you can't correlate the form with the sample. So the person can come back to you and say that I want the results for this sample. It's not because you couldn't, but you could not test because there was no label. So you can't match the sample to the particular form. That is a transcription error, and that is something that the lab can't do little about. It's not only that, it could be how it's transported to you. By the time the sample comes, it will have poured off, and when it pours off, there will be nothing in the container. So you may not be able to give a 24-hour or 48-hour short turnaround time results to the person because of this. And then we have the analytical errors or analytical problems. So when the sample comes, the nature of the sample also tells how long you have to spend on the sample. If you have a swab stick which you put in somebody's dose, it takes you mostly about 30 minutes to process. But if the person coughs sputum from the chest, it can take you 1 to 2 hours to process the sample. And this comes with its own delay. And then you have the post-analytical problems. When the result is finally out, and you transfer the results to a form, you need to channel the results through a communication channel. You send it to the Director of Public Health. You can send to the regional directors. It takes some time for them to also disseminate this down to the doctors who are managing the patient. And sometimes you could have 2 or 3 people with the same name and with ages which are similar. You need to call, verify, and be sure that you are dealing with the right patient. So these 3 phases are very important. And whenever you have a mix-up of any of this, it results in delay. And this could be the reason why we have some of these delays. But then the other reason also could be that we were talking about strategies.
Yeah.
As you enter into the 4th level, as I said, the WHO has about 4 levels. The first is when you have no cases in your country. The second is when you have a case in your country linked to 1 or 2 other cases. And the third is the sporadic, that is the sporadic case. The third is a case linked to clusters of cases. We have passed that point. Now we are at the point of large community spread.
Yeah.
When you get to this point and you have limited resources for testing, it's important that you begin to design what we call a priority testing strategy. And the priority testing strategy will mean that you must channel your testing to those who need it most before you begin to consider those who may need it less. I mean, if you tell me to come out with this or to recommend this, what I want to think about is what the US, for instance, have done. They have priority 1, which will mean that you first must make testing available to all vulnerable populations. So everybody who comes to the hospital is the first target. Whatever sentence he comes out with should be the first person to consider. And we have a surveillance strategy document which is developed from the Integrated Disease Surveillance Response System, which is available now, which is being used, which says that for any patient who comes at the 4th level with any form of influenza-like illness, symptoms of cough or fever, and then you have an unexplained, you have a presentation which is not linked to any unexplained diagnosis. You can't tell whether it's TB or it's malaria. You just can't tell what it is. Then you, of course, will have to rule out COVID. So you'll be having a number of those people coming, and because they need critical attention, their sample will be the first line of priority. The second will be those who are old, the elderly, above 60 years of age. If these people are sick with disease, pneumonia, or any kind of symptom, they become the next priority.
Because they're more vulnerable to die as a result of the COVID-19.
Of course, they are likely to die compared to an asymptomatic person who may have it in their community. And then the 3rd level will be looking out for people who are in clusters, in slums, where if 1 or 2 people have it, they are likely to spread at a very faster rate. This is important because we don't manufacture the reagent for testing. We import this. There are over 58 countries in the Western world who are reluctant to sell these reagents to us in the developing countries. The African CDC is aggressively making campaign, asking for solidarity for these countries, but then they are just unwilling. They are trying to channel their resources to do their own. It means that the little you have, you need to begin to have a strategy to channel those who need the most. If we still go by the strategy where we do mass testing for
which is the current strategy, by the way.
Yeah, so there will be a lot of pressure on the labs, and once the pressure mounts, those who need it most, who are the vulnerable, who are sick, who are likely to die, may not get their results in real time, and that can negatively impact. And if you don't take it, you may run out of reagents because you don't manufacture them. When you need it from a place to come to you, when you need it most to take care of the sick, you wouldn't find it because you will have channeled a lot of this into the communities where many are asymptomatic and many may not be presenting with illness.
But it's very interesting you make that point. So this strategy change primarily is influenced by the fact that we are seeing more community transmissions now than before.
Yeah, so as I said, is the ideal situation, like China did, like Singapore did, is to test everybody. Test. This is the strategy. But then you do this when you have available tests.
But we don't.
You have the luxury.
So that's where your priority comes in.
Because that is it. So
okay.
It means that at this point where you have a large community spread, everybody you see is a potential. The person may have it. But if those who are sick come to you and the reagents run out and it's getting finished,
then you've been in trouble.
How will you handle them?
Yeah, I mean, forgive me, let me bring in, because of time, I want to bring in Titus Berrio on this. So, Titus, that is the proposal for strategy change we're hearing from Dr. Osu. What do you make of that? And in the face of all that you've seen at the hospitals, should we change the strategy? Do you agree?
Definitely, I think there's a need for a change in strategy. And for me, I think that, well, I don't know in terms of the capacity, what quantities of test reagents we have. But the first recommended change in strategy I would want to see is a reorientation of our testing priorities. If it does exist, then it's not being practicalized. And when I say reorientation of testing priorities, we have lumped routine community samples, contact tracing samples with hospital-based samples and healthcare worker samples. So that it takes 12 days for you to get the results of healthcare workers when a department is closed down. I think that must change ASAP. All health worker samples, inpatient samples, just as he mentioned, that we need results to make a critical decision right from the pre-analytical stage. Sample processing, collection, their labeling and everything should be prioritized. And for patients who are ill and we need to take a decision, we want to see these results out as early as possible. I understand the various stages he's talked about and the fact that you cannot hurry it to make errors. But there are a few things when you see, it begs of the question whether there are no post-analytical delays that can be reduced. And I cited an example for you, where a regional coordinating council will hold a press conference, announce that the certified results we have received from the lab shows that our number is X. And on the Ghana Health Service platform, the number is still Y.
Yeah.
And it remains Y for 4 days.
Yeah.
That definitely cannot be a laboratory issue. It will be something that will be a post-analytical issue.
Yeah.
And I think that bit can be shortened. Now, going forward, if we want to change strategy, I think that change in strategy he has suggested will be very helpful, especially if we are beginning to run out of kits. We should prioritize our testing and test the people that we really have to get their report. But I also think that the next strategy we have to adopt is enhanced education. We have to change the narrative. Our current model of education has put in so much fear in people. And even though the virus is not giving us the figures of mortality like what we are seeing in Europe and other places, the fear we have put in our population has come along with a stigma. And I think the stigma is the next big thing that we must tackle.
Yeah.
And in tackling that, I have had patients personally appeal to me that can we beg the ambulance services, if they are coming to pick them from their community to isolation center, they shouldn't come with their sirens blaring, with full PPE and everything. And then once they are picked, their entire household is stigmatized. Yeah. People from that household cannot even buy food in the community. And there are rumors that everybody in that community, in that household, is
infected.
That is one area we must change strategy.
I mean, that
if
is certainly...
If we are picking up people to the treatment center, we should put in
stigmatization is. Thank you, gentlemen, for joining me on PM Express tonight. I mean, fascinating insights, especially Dr. Mesapia Hene, for your insight into the weather implications. You want to join us again on PM Express tomorrow, because definitely fascinating conversation again in 24 hours. My name is Evans. Enjoy the rest of the evening.